What's up guys, we got a Q&A for you guys ranging from topics of ACL, MPFL surgery, and also Osgood Schlatters. My name is Dr. Marco Lopez.
I'm Dr. Gabe Ignacio. We're doctors of physical therapy and co-founders of the Basketball Doctors. Like Marco mentioned, just want to do a Q&A session. We pulled these questions from things our audience has asked us on either previous videos, other social media. And you just want to pick the more common questions and we feel like we need to get into more detail of. Marco mentioned this is more of like a knee variety Q&A. If you have any more questions specifically about these topics, feel free to put them down in the comment section below, or if you have any other questions not related to these at all, please ask them below. If we'll try and answer them if we can in the text box below, but if we feel like if they need more detail or more in-depth answers, we'll grab them and answer them in our next Q&A session. So we're just gonna get into it now.
Let's jump into it.
First question is, I'm almost 7 months post-op ACL reconstruction. Doctor confirmed I have slight laxity, grade 1 laxity. I feel my knee is a bit loose. It's annoying. My surgeon said with more strength in the quads and hamstrings, that feeling should go away. Should I opt for revision surgery? Have people have gotten revision for their slight laxity? What are some of the outcomes of these revisions?
That's a great question. I mean, he's already kind of going too aggressive though, re-surgery already. But it is a common question. So what happens is, what we've seen throughout all the ACLs that we've seen is early on that ACL is very tight, you know, there's no laxity. And then as over time goes on, it gets a little lax, but it's still not like lax to the point where it's giving you instability or anything. But it is very common for people to feel a little bit lax, especially when I test some ACLs, you know, at month 6, 7, it's like, oh, it's a little loose, you know, versus the other side, but it's still not, it has an end feel, that's totally normal. But the biggest thing too, what, you know, the doctor even mentioned, you have to really get that quad and hamstring really strong because they're gonna provide that co-contraction, provide that stability in the knee. So at month 7, you should be in a good position where you're really strong. Hopefully we're at that 85–90% compared to the other side. But that's going to be providing that true stability of the knee, having that co-contraction in the quad and hamstring, and that's going to help keep that knee stable. But it's also pretty early on, has a lot of time to even strengthen, do all this stuff before they even think about revision surgery. Because honestly, the only time I would probably tell someone to consider that is if they have a lot of laxity, whether it's instability laxity, when their knee's giving out, and that's when we would kind of consider that revision. What do you think, Gabe?
Yeah, I think that's the biggest component, right? Marco mentioned it. We've seen so many athletes and so many people recover from ACL reconstruction. Fortunately or unfortunately, depending on how you look at it, is that when we test the ligament like months down the line, even like years past the line, there is just noticeable difference from the surgical leg to the non-surgical leg. But the big thing is, is there an end feel, which majority of the time there is. If there isn't, then you know, obviously we're going to send them to the surgeon, but majority of the time there is an end feel and they feel stable. The feeling of stability is the most important thing. Like when you're doing stuff, does your knee feel like it's giving out, or does it feel like it gives way? That's the big question that we ask people. If it doesn't, then that's a really good sign that the laxity isn't causing your instability. What Marco mentioned is the most important thing is the rehab. You gotta be not only strong in your quads and hamstrings, but doing the entire kinetic chain from your foot and ankle, the hip, the core. With movement, you gotta really make sure you own those movements now, especially if you're working with the right therapist. A lot of athletes that we work with, that after their journey, they actually feel like they're stronger, they move better, they're more explosive, they're more athletic because we break down their movement from the very beginning. Yeah, to answer this question though, the only time we really suggest doing surgery for revision is if there's that instability feeling or it's causing problems of giving out and stuff like that. We have seen people get revisions and it's the same thing. We just go through the same rehab protocol, but they do well. It's just a conversation between yourself, the surgeon, us, or whoever you're working with, if that's the right choice for you, essentially.
Yeah, and I guess the last thing that I would add in is was there any particular injury as well? I think he may even not, you know, if there was an injury and there was some laxity, then okay. Different story. So I guess we forgot to play that as a factor. But, you know, if you early on, like I said, the ACL is at that's most vulnerable stages between that month 4 to 6, you'd say, or 3 to 6, right?
Yeah.
In that middle stages where we still want to really work on strengthening. And sometimes some people do something they're not supposed to be doing, like cutting at month 3 or month 4 when they're not ready. And they might have some laxity, then that means they might have sprained it or something, you know, who knows. But I just thought about that. Maybe there's something more to that.
Yeah, it's so true. Like they said in research, the ligament is the most, like if you didn't have a failure early on, usually you have like an issue with the graft around that 9 to 12 week mark, because how the ligament essentially changes from the graft to ligament. It's usually that 9 to 12 week mark is when it's the most vulnerable. And as you know, like people will do what they want to do when they're not with their rehab specialist or whoever. Yeah. So you never know, maybe someone did something they shouldn't have. Things happen, just never know.
All right, guys, next question. We have an OSD question, Osgood Schlatter. So Bolfi 28, my son is 12, he has that pain, OSD, Osgood Schlatter, so that pain like right below the kneecap. Should I suggest him to rest while we stretch his muscles, and how long do you think he should rest? What do you think, Gabe?
Gotcha. So OSD, for those that don't know, it's Osgood Schlatter disease. It's actually a pretty common adolescent pathology that develops mostly with athletes between like ages 10 to 12 and lasts till like 16 to 18, usually when you're growing and your bones are a little bit immature. So it's one where I had it personally growing up, and both my knees actually, when I hit my growth spurt when I was a sophomore in high school, and it was not fun at all. And then I had another one that flared up in my senior year of high school, and it's not a fun injury to do with. I wasn't educated during that time. I saw a PT maybe like once or twice and didn't listen and tried to play through it and cause more problems. So to answer this guy's question, how long do you think you should rest? So the first part to answer is like how acutely aggravated or like how recently aggravated is the symptoms, because if it's uncomfortable just walking, sitting through class, and it's a pretty flared up and irritated disease at that point. So you really want to calm that thing down, like stretching and maybe doing a light activity, icing and stuff like that is probably your best bet until it decreases to a point where he's not having pain with like going to school, sitting through classes, walking around. You want to make sure they're comfortable first. Like that's the main priority. And then maybe in the later stages when they have like no pain with everyday activities, that's when you could start progressively overloading a little bit, like working on movement retraining a little bit. Not really loading up the quads too much yet. You're working on other things like the posterior chain, like your glutes, hamstring, calves, things like that. But to answer his question is that you should be doing stuff while they're resting or not playing sport or like not doing like weight training or things like that. There's a lot of stuff you can do that isn't too aggressive, but we need to figure out what stage of irritation they are.
Yeah. Gabe mentioned some great points there. The biggest thing is you don't want to completely rest it. You know, there's always some exercise you can do, like Gabe mentioned, posterior chain. There's also a great online research that we have, Osgood Schlatter's Rehab program. It's all online. You can go step by step. It tells you how to manage your flare-ups. But it's all kind of just like managing these flare-ups, managing these irritations. And I don't want to scare people, but sometimes when you play through it, you might have an avulsion fracture. I've seen it a couple times. People kind of push through it. So you got to really listen to your body, have the kids not push it through much to pain. And like Gabe mentioned, there's different things that we can work on posterior chain. So check out our Osgood Schlatter's Rehab program. It's all online. You can do it at home, but there's a lot of things that you can be doing just instead of just resting and stretching. Right?
Yeah, it's one of the ones that you will grow out of it with time. It's ones that when it is flared up is very uncomfortable. Educate your kid on listening to their body. It's a good time to teach them what's good pain and bad pain. If you're not comfortable doing that, reach out to a healthcare specialist to have that conversation with them. I was at that age. I didn't listen, and I ended up being in crutches because I was I was dumb and tried to play through it. And yeah, luckily I didn't have an avulsion fracture, but that is like the biggest risk factor. If you keep playing and keep pulling at that bony area, our bones are immature enough so that when you have a contraction, that quad tendon, patella tendon will just rip off that bone. So it's one of the ones where it's a time at their life where it can be a blessing in disguise, where you can retrain them how to move properly. When I was at that age, I was very knee dominant playing basketball. We know it's like everything's quad dominant. Could have rebalanced myself to work on like being more hip dominant, retraining my body how to move better, stuff like that. So there can be always a silver lining to any bad situation. So the last question here is from Basketball Videos 448. They said, I have pain on the bottom of my kneecap that spreads laterally or to the side. I've had an MPFL reconstruction done 2 years ago. The pain increases when jumping, landing, and running. I don't know if I have jumper's knee or PFPS. MRI showed that the bottom of the kneecap has edema and my patella tendon looked okay. Any suggestions?
It's a great question. So MPFL, guys, or let's just kind of retract. So MPFL reconstruction, that usually happens when you dislocate your kneecap. It's usually after you dislocate it like multiple times, or you have that instability, and they reconstruct that medial patellofemoral ligament, which is the inside part of your kneecap that keeps it stable from going out to the side. But because he has pain when he's doing these running and jumping activities, we're thinking maybe it's jumper's knee or maybe it's patellofemoral pain syndrome, but most likely it's more patellofemoral pain syndrome. And another thing we would ask is like, maybe does it hurt going down the stairs, or does it hurt when you're sitting, when your knee bent for a prolonged period of time? We're thinking more patellofemoral in nature, especially because given the history of patellofemoral issues. And in the MRI, you know, they showed nothing in the MRI for the patellar tendon, but there's some swelling below the kneecap from what I remember in the question, right? Yeah. Sometimes also, I mean, we can't technically rule out, you know, some fat pad irritation that might show up with some little swelling, but also it could be just the kneecap itself irritated. But we're thinking patellofemoral pain syndrome. And with that, there's different, you know, things that we have to look into, looking at alignment of the body in a way when you're doing squats, lunges, doing different movements when you're jumping, running. Are you coming in a little bit too much inward or anything? Or let's look at your ankle mobility, let's look at your hip strength, let's look at your quad strength. Maybe you're still not fully recovered from the MPFL surgery itself, but I don't think it's the MPFL. A lot of the times people say like, oh, it's, you know, my surgery, the thing that we fixed in the surgery is causing my pain. The MPFL won't most likely give you the pain itself. It's going to be more the patellofemoral structure, I think, or, you know, some other structure itself. What do you think, Gabe?
Yeah, I mean, it sounds like there's other things going on rather than like a jumper's knee issue, especially with the MRI finding real no like signal or anything at the patellar tendon. Could be like a mobility issue of the kneecap itself. Maybe it got really stiff from the reconstruction. The knee joint itself might be still stiff. There's something that's not moving correctly that's causing edema at the bottom of his kneecap. So that's probably where we're trying to figure out where the source of that issue is, and then figure out where the impairments are to correct any impairments to get them to move better and hopefully get them out of pain. So that's one where unravel kind of what's actually going on. Like 2 years ago I had a surgery, could be still playing a factor, like where's the mobility deficits, where the strength deficits are, where's the movement compromise, and developing a plan for them to meet their needs and goals essentially. So this one's kind of more of like, do you need someone, they need to work with somebody or work with us to kind of unpack what's going on and get a individualized treatment plan for them essentially. It's kind of what I'm thinking.
Yeah, I think looking at, you know, I think first of all, let's see how they land from the jump. They're saying landing, you know, running, jumping. Let's start off with just analyzing the movement, and then like Gabe said, let's look at what impairments we have. Maybe we don't even go through the diagnosis route. Yeah. Let's just figure out what's, you know, causing them. Let's just kind of fix up their movement. We are, you know, optimize the movement a little bit. Maybe their pain goes away from there. But yeah, I think this requires, you know, some working with a healthcare provider. So if you're listening, send us a DM or an email and see if we could work with you virtually or in person to really kind of find out what's causing this pain, you know, and I think it might be from some movement. And a lot of times patellofemoral pain syndrome comes from abnormal movements, putting too much pressure on that patellofemoral joint there.
So that pretty much wraps up this session for our Q&A. Like we said, if you have any specific questions about the topics that we just talked about or need more information, comment down below, ask those questions. If you have any questions regarding anything at all, and ask them below, we'll get to them in the comment section if we can. If it needs more in-depth answers, we'll pull that question and answer our next Q&A. But like always, we appreciate you guys listening in.
If you guys have any questions, ask them below. These are some good questions. We're, like Gabe said, we're picking the best questions that we can explain a little bit more. But yeah, hit the like button, share button, subscribe, and we are the Basketball Doctors. Let's go for life.